Good afternoon, everyone, and welcome to our Protect Our Province pop-up briefing for Alberta. We are live streaming from the traditional and ancestral territory of many peoples. We are grateful to live and work in Alberta, a province on the traditional territory of 48 different First Nations and the unceded homeland of the Métis Nation. Today's conversation is not being shared in ASL, but to ensure completely accurate access to information, closed captioning will be uploaded after the live stream is complete. This conversation for the public is being shared live on YouTube, X, formerly known as Twitter, and Facebook. The views of our panelists are their own and do not represent any institutions they may be affiliated with. We have collectively gathered here as concerned Albertans, attempting to ensure that everyone in the province has access to as much information concerning the current state of our healthcare system. Hello, everyone, and thank you for joining us for this special edition, pop-up edition of Pop Alberta. It's been a while since we have connected in this format, and although I wish it hadn't been necessary, all of us at PoPAB thank you very much for tuning in. We're going to be exploring what is happening in Alberta today with some familiar faces from previous briefings. A lot has been happening in the world of Alberta healthcare over the last few weeks, some of which we will talk about today, and some of it we will cover over the coming weeks. Well, it would be nice to have said goodbye to the COVID-19 pandemic. Unfortunately, we really cannot, nor can we ignore what is happening in our homes, communities, and hospitals. So to start today off, I am pleased to welcome Dr. Joe Vipond on screen for an update on COVID-19 in Alberta.
Thanks,
Hi,
Michelle.
Dr. Vipond.
Thanks, Michelle, for hosting us again, and welcome to our audience. I'm hoping there's some media out there. I'm hoping some people still care about this, because honestly, the government has done a very concerted effort to make us not care about this. Just some statistics. I don't believe, and correct me if I'm wrong, that despite the hundreds of deaths that have happened since our premier was elected to her leadership position over a year ago, I don't believe she's ever sent her condolences to the deaths, the people that have died of this preventable infectious disease. We haven't had a CMOH COVID briefing since June of 2022. That's I don't know, calculated, probably about 16 months now. And we really, aside from the occasional pop-up media piece, we really aren't talking about what's happening in this province. So I don't know. It's out there. It's around the world. It's not just Alberta. This isn't an Alberta specific phenomenon, but it's where I live, and so it's what I care about. And I'm just hoping that others will care as well. So maybe we'll go straight to the slides. Unlike previous presentations, I don't know if those are my slides. I'm thinking those are Goja slides. There we go. Mostly what I'm going to talk about is what you can see online and why it may not be as accurate as you may want it to be. And I'll try and fill in some of those gaps. There is a new respiratory virus reporting website. This is the front page for it here, the highlights, as they say. A lot of people don't go beyond this, but we will go beyond this. And I think one thing I want to draw attention to is the blue in the center, and I really want to focus on the COVID numbers. But while we're on this page, let's just take a look at some of the information. So first of all, the information here is for a 1 week period of time. And I think you can see pretty vividly that the COVID stats are much worse than any other stat there. So, many more cases. I think we got very small. Many more cases, many more hospitalizations, many more deaths. In fact, infinitely more deaths because there have been no influenza deaths this season. Same goes for RSV. We're not really into the RSV season yet, so there are some sporadic cases, but it's certainly not a big issue like it was this time last year. Next slide, please. So, there's two slides there. It was supposed to come up separately. What I'm trying to do with these two slides is talk about how the case numbers are essentially irrelevant. Um, Up until January of 2022, pretty much anybody could get a COVID test in Alberta if they had any symptoms at all. Even if you were leaving the country and wanted to go traveling, you wanted to make sure you weren't going to infect everybody on the plane. You could get a COVID test, a PCR test. And so since that period of time, all stats on cases are pretty much useless. So this is on the statistics webpage, but you can see it's pretty comforting, right? Like, wow, we're way better today than we were 2 years ago. But in actual fact, it's total balderdash. It doesn't reflect what's happening on the ground. Really, the only from what I understand, and is that the difference is that the only people getting tested right now are those that are sick enough to appear in a hospital in some place, and perhaps some long-term care centers as well. But beyond that, the general population is not being tested. Goja has just posted in our chat that there have been 4 deaths this season. That stat was for that 1 week period where there were no deaths. Next slide, please. So you can also find this. This is by age. This is more reflective of not cases per age, but hospitalizations. So this could be a pretty useful web page, because if only those that are being hospitalized or presenting to the emergency room are getting tested, this would reflect who is still being impacted. And as you can see, it's predominantly still the 70 and 80 and above, as well as the under 1. And I think we often forget that it's the under 1s that are also impacted by this. Next slide, please. And again, looking at hospitalizations, this is another web page. There's that thick dotted line halfway through where the reporting changed. So what does that mean, the reporting changed? So first of all, this is different than the graphic that we used to look at, which was at how many people are in hospital with COVID. This is actually not that. This represents how many people have been admitted to the hospital in the last 7 days. And that's a very different stat, because depending on how long someone's in hospital can have an impact of how much of a challenge this is for our hospital system. My understanding is that dark hashed line is where they went from reporting all types of COVID admissions to only 2 types: those that are deemed to be directly attributable to COVID, and those that are being where COVID is a contributing factor. So what are the other possible categories? Where COVID is deemed incidental, or where it's undetermined, so they actually don't know. And my understanding from looking at the AHS numbers on the inside is that it's about a third difference from what's being reported. So about a third of the patients are being categorized in this reportable category, and the rest are not. And just remember that the non-determinant category is pretty big, where they don't know. And so I personally would say we're not being told accurate hospitalization stats because of the way they're reporting this. The other thing I'd like to point out is that we don't know who is making that determination and on what basis. My sense is that in some jurisdictions, being admitted for COVID means you have the respiratory illness. So that respiratory component where they have that COVID pneumonia is considered for COVID, and any other contributory factor would be associated with. So, what does that mean for somebody who, like, in the last couple of years with Omicron, the most common presentation for the elderly was an unexplained fall. People were just too weak to get around. They were coping prior to getting ill. They got ill, they started falling. Sometimes they broke a hip. Is that broken hip considered to be from COVID, associated with COVID? uh, or irrespective of COVID. I don't understand who's making that determination. I've seen COVID admissions for low sodium rates. That's a salt in your blood. I've seen it for hepatitis. Um, uh, Multiple different organ systems can be impacted by COVID, and I don't understand who is determining what element of that it is. And of course, we know that people who are admitted to hospital with COVID have higher mortality rates. And of course, they can have an impact on the system because it's an infectious disease and they can infect other people. So I have concerns. I'd love to hear some of our media approach our hospital leaders to figure out exactly what all this means. Next slide, please. Um, and then this is interesting. These are virus outbreaks. My understanding is this includes long-term care, this includes prisons, this includes hospitals. And I just want to say kudos to the Edmonton area for all of their hospitals being instituting a mask mandate. As far as I know, in Calgary, there's only one facility that's instituted a mask mandate, and that's the Tom Baker Cancer Center. Thank you to them. But one of the things I really want to point out here is how many outbreaks there are across the province, and Calgary is no exception to that. And remember that masks protect not just against COVID-19, but protects against influenza, protects against human metapneumovirus. All of these are respiratory illnesses. The vast majority of them are transmitted through airborne means. The better mask you're wearing, the better off you are from being protected and protecting your patients. Next slide, please. I just want to touch on wastewater. I have never, ever commented on wastewater because personally, I don't understand it. I don't understand what it means for this reporting to start on 1st of July versus we've been doing wastewater for years. How does today's compare to, January of 2022 when we had the highest rates of transmission of Omicron? I don't understand this, but this is on the website. Hopefully someday we'll have PoPAB Alberta will have somebody who understands the nuances of wastewater to talk about this. Next slide, please. And I just want to touch on acute care outbreaks. We have 6 pages of acute care outbreaks that are reported every single week. The last one was reported yesterday. I have in the past been going through and reporting on the various numbers, watching them go up and up and up. And now we seem to have stabilized at a very high rate. Some of the numbers that I've seen suggest that 50% of patients in some of the hospitals have gotten COVID in the hospital, which is a stunning statistic. I've always been an advocate for universal hospital masking, and in particular respiratory style N95 masks, because we know they provide better protection. It's tragic to me that vulnerable people are going into our hospitals for simple things like hip fractures, repairs, or total knee replacements, and they're getting this illness, and some of them are dying. I ask the media out there to please look into what these numbers mean for Albertan patients. Our vulnerable deserve all the protection that they can get. And I believe there's one more slide, and then we'll leave it at that. There are a few media that still care about this. Adam Toy and Kyra Markov, Adam of Global, Kyra of CTV, are still doing good reporting on the numbers. Not every week, but when they do report, they can be relied on. And Jen Lee of the CBC is still doing excellent COVID reporting on beyond the statistics. And so I encourage people to follow their work, and I encourage more media to still care about this, because it's having an impact on our society, even though we're hiding it. I turn it back over to you, Michelle.
Thank you very much, Dr. Vipond. It is lovely to have this opportunity to have this conversation with you. I'm sad that we are having it again after having had it so many times, but it is lovely to have you here with us today. So thank you very, very much for your time. So a little bit of where we are, I guess, now into where we are possibly headed. There's still a lot, obviously, that we don't know about long COVID and about the effects of repeated infection with COVID-19. But since we last had the opportunity to all come together in this medium, a lot of research is done and a lot of deeper understanding has taken root. So, on that, I would like to welcome Dr. Gosia Gasparovich back into the conversation to give us her fantastic biological numerological insight into where we could be headed and what new things have been discovered. Thank you so much for being with us.
Thank you so much, Michelle. Good afternoon, everyone. So yeah, we didn't see each other since 1.5 years. A lot of things happened, and I have to say that I have a trouble to squeeze all the knowledge from the last 1.5 years about COVID to just a few minutes of presentation. But I would like to share something with you. So first, can I get first slide? So it's basically what Dr. Vipond said already, just in a little bit different form. So basically what we have now in Alberta is mostly COVID. And so this season we had 1,600 hospitalizations, and season started August 27, compared to flu, which is 90 hospitalizations, 78 ICUs versus 9 ICUs, and 175 deaths versus 4 deaths. So COVID is much, much, much more terrible than influenza is. Next slide, please. Also, here, the slide that we've just seen about outbreaks, but I wanted to point out that mostly outbreaks are COVID. 443. The next one is unspecified respiratory illness, which is 77, which is 5 times less, and then rhinovirus or flu. So predominantly, those are COVID outbreaks. Next slide, please. And now the context, what happened since beginning of 2022. So this graph shows the, I feel that I cannot use the mouse to point on the stuff here. So on the x-axis, we have time. On the y-axis, percent of people being seropositive for antibodies against COVID from infection. So basically, how many people in percentage got infected with SARS-2. And blue dots are younger people, red dots are older people. And we see that around in February, we started really mass infection of Canadians. And since then, vast majority of people get infected at least once, very often 2 times, 3 times, 4 times. So 2022, January, February, it's when mass infection started. Next slide, please. Okay, and when people get infected, people get sick. And here is the data from Canada, total patients hospitalized. And now it's patients from COVID or COVID as contributing factor, not incidental cases, again, across Canada. And we can see that we have like 4,000 patients now at any given time in a hospital. It was a little bit lower during summer, but basically it's high level all the time. So it's not a seasonal respiratory virus. Next slide, please. COVID kills. That's a graph showing excess deaths from Professor Tara Moriarty lab. it excludes the excess death mortality due to drug poisoning, heat domes, etc. So probably most of it is delayed deaths from COVID. So some people die because of COVID immediately, like during acute phase, and some die because of post-COVID condition or some heart attacks or something like this. So we see that since the beginning of the pandemic, the excess deaths really lined well with COVID waves. Now COVID reporting is really low, but we can see it. So the excess deaths here are those gray bars. So they are still high and they are growing. And important thing there was that I've seen the analysis of excess deaths that showed that actually the biggest increase, the largest increase in percentage is in the younger groups, so below 44 years old. So now it sort of shifts. This excess mortality increases more in the younger population. Next slide, please. So SARS-2 causes long COVID. Well, we probably should devote another briefing just to long COVID. So 10 to 20% people infected with SARS-2 can develop long COVID. Now it's around 10%. 16% of Canadian adults infected with SARS-2 have long COVID, which is about 1.3 million people, and 4% of all adults in Canada. 47% of them have it for a year or longer, and 1 in 5 among them have limiting daily activities. Kids develop long COVID too, and SARS-2 causes cognitive decline. SARS-2 causes cardiovascular problems as well. Next slide, please. And here's really something I would like a lot of people to understand. So it's just mathematical exercise. It's cumulative probability of the bad outcome. So we don't know really how much of a risk of cardiovascular damage we have per infection. Is our second infection better or worse, or fifth infection is better or worse per infection? But no matter how high it is per infection, playing it again and again is like playing Russian roulette. So you can be lucky one time, you can be lucky 2 times, 3 times, but if you play it 20 times, your chances are increasing dramatically of having a bad outcome. So here are the lines, like just theoretical, showing how much the cumulative risk increases with the number of hits. If we have 1% per infection risk, or 5%, or 10% of 20%. We are somewhere between 5% and 10%. I think that's made the best sense right now, but I don't know. So we see that by 10th infection, we can be in 50% cumulative risk territory, which is really, really bad. And I don't think I would like to run this experiment on the population. So next slide, please. And now I would like to talk about SARS-2 and children, babies, and fetuses. So next slide, please. First thing, I would like to put some historical context. So children are not naturally resilient. We've heard so much during the last 4 years that, oh, children are resilient. They are made of rubber. Basically, they can survive everything. And it's not true. Naturally, they are not resilient. In the historical times, so this graph is from the report written by by Max Roser and published in Our World in Data. So on the x-axis, we have time, and on the y-axis, it's a percentage of children that died before reaching adulthood, so before being 15 years old. So we see that in historical times, half of the children didn't survive past 15 years old. And then just in the 20th century, during the 20th century, we made so much progress. We brought it down to basically more than 99% of children in Canada surviving into adulthood. Next slide, please. And when we look into children less than 5 years old, at the beginning of 20th century, early like 1910s, 1920s, 30% of children in Canada died before age of 5. And then something happened, And then we drove it much, 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 much lower, and now it's only 0.5%. And that's because for 100 last what, and it's unprecedented in history. So we basically made children sort of immortal, from being very mortal to being almost immortal. And we did it because of the guiding principle that we have for the last 100 years of living without pathogens. And that's really super important. So we use sanitation, hygiene, antibiotics, pasteurization, universal immunization, and public health campaigns to not infect children, to keep them away from pathogens and keep them vaccinated so pathogens don't harm them. And so that's the historical context. But during last 2-3 years, something really, really very strange happened. Next slide, please. So basically, this principle seems to be ditched. Like, it seems that we did something totally opposite since the beginning of 2022. So it's again the slide showing how many people got infected with SARS-2 in Canada, and the blue dots are younger people. So since the beginning of 2022 till now, we infected almost all the children with SARS-2, and we're keeping reinfecting them, which is totally opposite to the philosophy that was guiding us for the last 100 years. And yeah, so we've been told that, and it almost looks like it was done on purpose, because we didn't need to infect them. Masks, we could keep masks, we could have kept masks in schools, we could have vaccinated them more, and only 40% of kids have to, in elementary schools from 5 to 12 years old, have 2 vaccine doses, right? So we just dropped them into the virus unprotected. And actually the mask mandates have been dropped in February 2022 in Alberta. So yeah, we've been told that COVID doesn't harm children, and that's why we can infect them, that COVID is milder than flu, and so on and so on. Next slide, please. And that's simply not true. COVID is more harmful than influenza for children, and we can see this on this graph. So it killed in 2021, and in 2022 it killed more children than influenza does in the typical season. So in typical season, influenza on average kills 9 children in Canada, and minimal from 2011, 2012 till 2019, 2020. So minimal was 5 deaths, maximal 13. So 42 is much, much more. And the study done on American children showed that COVID or SARS-2 is #1 cause of infectious disease-driven deaths in children. So it's the most deadly at the moment infectious disease in pediatric population. Next slide, please. And okay, so now let's come to the fetuses. So that when the body of before child is born, when the organism develops. So COVID SARS-2 harms fetuses via harming placenta. So we've seen a lot of publications showing structural changes, like dramatic structural changes in placenta. So abnormal shape, thickening, hemorrhages, and basically making it like very unpermeable, sort of. So placenta is this organ that is probably like we couldn't live without placenta, and it has blood from the mother coming in and blood from the circulation from the fetus on the other side. The blood systems the blood doesn't mix, but through the cells there is a transport of nutrients, transport of oxygen from the maternal blood to children, like fetal blood. And so if it doesn't work, if maternal blood cannot go well into placenta, then the child cannot be fed properly. There's not enough oxygen in their tissue. So that results in suboptimal development, in intrauterine growth restriction, in preterm births and stillbirths, and that's what we've been seeing. Also, infection with SARS-2 damages placenta's immune response to further infections. SARS-2 can infect also the fetus directly, and it can cause brain damage. But fortunately, placenta makes a barrier, and not always infected mad like SARS-2 can pass it. So not always SARS-2 infects fetuses, even if the mother is infected, but it can totally affect placenta, and it's dangerous. Next slide, please. Okay, so here's the calculation I did yesterday on the basis of Alberta Health report and statistic web page. So actually, COVID harms very much babies, the ones less than 1 year old. We see that the hospitalization rate of less than 1 year old is at the level almost as high as people 70, 79 years old. And it's higher than 60, 69 years old, which is very high. And we know that less than 1 year olds are very fragile and vulnerable. They are not well, they don't have well-developed immune system. And we don't vaccinate less than 6 months old babies. So there's no vaccine for them. So basically, if they get infected, it's just their system has to fight it. And we see that it can't so well, it cannot do it so well. So it's really, we just seems that we didn't care about them. And next slide, please. And that's even worse thing. So it's the rate of ICU admissions for different age groups, and we see that less than 1 year old the babies have the highest ICU admission, and it's the season. So this season, babies have the highest ICU admission among all the age groups. And okay, so we did it to children that were born in 2022, in 2023, and I hope we will stop doing it. Because like really this generation, the children that have been born during last 2 years, this cohort will have problems going on, will have health problems in the future. So I think we will stop, and we will make sure that children born now or born in 2024 won't get infected. So yeah, so we know, okay, it's 33. So yeah, I can show what we can do, because, so next slide, please. And next one. Because fortunately, like, COVID is not such an amazingly strong virus. Like, we can fight it. We know that it's airborne. We know that virus-containing aerosols can float like a smoke and accumulate in room for hours. So it transmits via short-range aerosol transmission and long-range aerosol transmission. And it's totally preventable. Next slide, please. So we can prevent long-range aerosol transmission by air filtration and ventilation. Next slide, please. But we cannot prevent by this short-range aerosol transmission. By wearing respirators, we can protect ourselves, but babies cannot protect themselves. So if we put baby in such room, the baby will get infected. That's why, next slide, please, the two-way masking is extremely important. So it's very important that we have that infectious person, and we don't know who is infectious, wears respirator as well, so that the common shared air is not infected, not contaminated. So if we would put baby in this room, the baby wouldn't get infected. Next slide, please. And if we use also air filtration and ventilation, then everybody in such shared room would be safe. Next slide. And here are two very good articles that, I really like them. One by Blake Murdoch of his own opinion about treating kids as invulnerable is treating them as disposable. It's published in Calgary Herald. And the recent editorial by John Snow Project, which is also very interesting. Thank you very much.
Thank you very much, Dr. Kasparovich. I'm going to bring back in Dr. Vipond, and I'm going to bring in Dr. Bakshi to welcome her to our conversation. If you were a regular viewer of our briefings before, I am sure that you are familiar with Dr. Bakshi, but I am a human who does not like to speak for others, and I prefer to have them speak for themselves. So I would love to invite you to give an introduction of yourself for those who are not familiar with you, as well as from what lens you are joining our conversation today. While that is happening, I encourage anyone at home with any questions to please feel free to pop them into the chats if you are viewing on a device that has chat capability. I am attempting to monitor as we go, and I will attempt to pose things that work into our conversation as I can. So, Dr. Rakshi, before we start talking, please share your lens for today.
Sure. Thanks, Michelle. As everybody said, I'm happy to be back, but not happy to be back. I'm speaking from the lens as an internal medicine physician based out of Edmonton. I work at the Royal Alexandra Hospital in acute care medicine, was part of the acute care COVID response. And I also have my own clinic in Sherwood Park, which is just outside of Edmonton, where I now run a long COVID program, one of only 3 in Alberta. The other 2 are affiliated with universities, and one of very few in the entire country. So COVID has not left us, but COVID certainly has not left my clinical practice at all. And so I'm happy to talk about acute care hospital and kind of what is happening, but we can also leave it up for questions if we want to start with that, Michelle.
Actually, I wouldn't mind if you would have a few more thoughts on that as we're gathering some questions, just because I think that some of them fall really nicely into that. So a bit of an overview around what is happening in your universe of acute care would be fantastic. Thank you.
Sure. So, I think Dr. Vipond really did highlight kind of the challenge with the data that we have and what we're really seeing in hospital. And I think it is very complex now because we are navigating the respiratory virus season, but we're also dealing with lots of outbreaks. And so the complexity that is COVID in hospital is very, very challenging to parse out. What are we seeing in terms of clinical care? What we are seeing is that capacity is a problem in acute care. And this was actually a problem even kind of 2-3 years ago, but not to the level that we're seeing now. I've talked a lot about, if you follow me on social media, I've talked a lot about overcapacity. And during kind of the height of the pandemics and all of the waves that we had, we were seeing numbers, 20, 30, 40, 50% over our bed base. But what we have seen actually since the height of the pandemic, and even in times where we've seen a bit of a slump. So for example, this past summer, we continue to see overcapacity as a problem. And I'm going to bring that back into why that matters in terms of COVID. But from a general perspective, our healthcare system, not just in Alberta, but really all through Canada, is crumbling. We have an aging population. People are living longer, and our infrastructure has not changed. In Edmonton, the newest hospital that was built was actually in 1988. And if we think about how much population has grown since then, we certainly have not been able to keep up. But as we go through the last 3 years, what we have noticed is not only an increase in admissions due to COVID, but also complications that have occurred because of whether a patient had COVID or complications from being able to access care. Our overall volume in hospital has been steadily increasing. Over the last few months, what we have noticed since August, since we started to see increase in COVID numbers in hospital, is that we are having increasingly difficult time getting patients out of hospital due to hospital outbreaks, due to infections within the hospital. And this is causing a backlog in being able to admit patients in. And so over the last few weeks, you may have seen in the news that various hospitals around the provinces weren't able to admit patients, or patients were being held in emergency rooms. I don't foresee that this is going to be a problem that goes away, particularly during this respiratory virus season. We are starting to see an uptick in influenza cases as well in the hospital. And this is a problem that we had, again, before COVID, before 2020. Influenza season in hospital was challenging. Now we have an extra virus that we are contending with. And between outbreaks, old infrastructure, and just sheer volume of patients, our systems are really under the pressure. What we need to add to that and talk about a little bit is also our staffing shortages. So when we talked about a capacity, we talk about capacity in terms of physical space, but we also have to think about capacity in terms of actual human resources. More and more physicians, I can speak from that lens, more and more physicians are starting to cut back how much work they can do because of the burnout from the pandemic. What this creates is a challenge in workforce and leaving many services uncovered, which then leads to patient safety concerns and an inability to provide the care that we really want to provide. We're seeing this both in acute care. We're seeing this in family medicine outpatient. I know that's going to be a topic that we discuss in the coming weeks. And so we're really setting ourselves up for full system failure over the next few months as we go into deep to the respiratory virus season. As both Gosia and Joe had kind of alluded to, this is something that is not going away, but this is something that we can do something about, right? It's not that there aren't solutions available. Masking and ventilation are not going to solve our capacity issue per se, but it will allow us to have better flow through the system, better care for our patients in the system, allow our more vulnerable patients to feel safe when they come to the hospital. These are all strategies that I think we need to do. And while we don't have all the time in the world to delve into long COVID, I think that's really important that we don't forget to talk about the long-term implications of COVID. As we have the long COVID program here in Edmonton, our referrals are not slowing down. The number of people that continue to suffer from long COVID from their acute COVID infections is high. So I just want to echo that I think that there's a lot that we can do and should be doing that isn't that hard. And I think I'll hand back over to you, Michelle.
Thank you so very much for that, Dr. Bakshi. There's actually a number of questions that related to exactly what you were talking about that I am going to pose to the panel now. As always, we aim to keep this conversational. So these questions are for all of you. Feel free to add as you see fit. The conversation around RSV, we've had a number of folks, sorry, I had a strange echo. We have had a number of folks ask about the efficacy of this year's vaccine. Does anyone have any comments? Oh, look, Chad's putting some of them up from the YouTube right there on the screen.
I'll just say that I've never professed to be a vaccine expert on COVID vaccines or any other vaccines. It really is a niche issue. And if I were to want to keep up on all the data on the vaccines on top of everything else, I'd probably drown. So I will respectfully decline to answer that.
Yeah, unfortunately, Michelle, I don't think I can give you too much information on efficacy for RSV vaccine. It is encouraging to see that we are getting more layers of protection as we start to see more and more respiratory viruses. But yeah, I don't think I can profess to say I know.
I do know a little bit that it's for, I believe, 65 and up. I might be getting the exact age wrong. It's not for the little kids. And as anybody who has a parent knows, that RSV is the one that gets you when you're really young, and certainly the very young, like the less than 2, hospitalized when they're when they're very young because of their very small airways. So unfortunately, it won't be helping those little kidlets.
Thank you both for acknowledging that virology and vaccine development is not your area of expertise. One of the things that I truly value about these conversations is our ability to say, we don't know. We'll try to find an expert for a future briefing who does, versus the desire of many folks to pontificate on things that they really have no business speaking about. So from the bottom of my heart as an Albertan, thank you for not just spouting things to fill airwaves. Really appreciate it. We did have a question on COVID related. If you have been previously vaccinated with the last round of things, why should you get this recent one? Why does it matter?
I can take this one. So I think what's important about the vaccines, especially the current one with the protection for XBB, is that as we've learned over the last 3 years, variants change, and much like the flu shot. Actually, if we really want to go back, the flu shot every year is adapted and adapted to kind of what the predominant strain was in the previous season, the previous year, to provide the most protection possible. With COVID, we know that various variants present differently and protection is different. We also know that COVID vaccine protection is not lifelong, much like the flu shot. So looking at this similarly as you wipe the flu shot, that every year we're told to get the flu shot, and that's because protection doesn't last. Protection changes based on the previous strain. I think it's important to recognize that the same will likely go for COVID moving forward.
Does anyone else have anything that they would like to add to what Dr. Bakshi has said?
I would just remind people that yeah, the vaccine works, but it really only works on the decreasing deaths, hospitalizations, and ICUs. It does not. It may decrease transmission somewhat, but not enough that you can just drop everything. I think everybody knows someone who's been fully vaccinated and has had COVID since. And I guess that's why the other layers are important, why we need to improve our ventilation and filtration in schools, because 70% of infections that come into a household come from little kids. And that's why we need to be doing good indoor masking when there are peaks like we are in right now.
The other thing, Michelle, I'll just add as well is I get a question a lot in my clinic around people who are suffering with long COVID on whether or not they should get vaccinated. Will it help with their long COVID? Number one, I think ultimately I'm still going to promote vaccination, whether you have long COVID or not. I still talk to my patients on a case-by-case basis because there are always concerns. And I think it's important to hear those concerns and understand where they're coming from. But there was a study that was published out of Quebec early October. It was a small study, but it showed that patients who had long COVID who then got boosters, this was looking at kind of before this current campaign, something around 70% of those patients reported an improvement in their symptoms with long COVID after getting vaccinated. There was a small percentage that felt that their symptoms did get worse, and so I think that's important to also comment on. But I think that there is still far more evidence that outweighs the benefits of the vaccine than the risks.
Anecdotally, that was an experience of one of my friends, actually, that they had been struggling with some long COVID and post-COVID symptoms. And when they received their booster, sort of been last year's one, not this year's one, so probably that similar cohort, they experienced quite a reduction in their symptoms from their post-COVID infection. And I know Dr. Gasparovitz just has something to add.
So I would like to add to what Dr. Bakshi said from the other end, sort of, like that the next infection with COVID. So that's what I heard anecdotally from people from long COVID advocacy, that sometimes some people had long COVID, sort of moderate one, that felt like being hungover and having headaches and such thing. The next infection tipped them over to having really very, very bad long COVID. So that's why vaccination is important to prevent the worsening long COVID with the next infection.
And just following up on that, so that's kind of the anecdote. Do we actually have good evidence as to what happens to long COVID patients that get reinfected? Because I'm hearing a lot of that, but I'm just not sure what it means for those patients.
Yeah, it's a great question. We don't have the data. It is being looked at right now in Toronto. Anecdotally, so we've seen about 400 to 500 patients in our clinic. I would say it's a little bit of a mixed bag. It's hard for me to say one way or the other that everybody who gets COVID, who has long COVID, gets worse. Some of it is, I think, because if you're a patient in our clinic, we really stress that if you get acutely ill with anything, that you actually need to rest and recover, and we go through all these various strategies. So I think a lot of patients who have long COVID are more acutely aware of the potential complications and the symptoms that they had the first time around. So they do everything in their power to kind of avoid getting worse. But right now, I would say, a good 15-20% of my long COVID patients are going through COVID right now in the last 1 week. I have the number of calls that I've received of these patients having COVID again. And so time will tell. I think that there is very real risk for things to get worse. But the silver lining, like I said, is that I think people with long COVID are very in tune with their symptoms and in tune with what they're feeling. And so they tend to take more precautionary measures to avoid overstimulation.
On that long COVID topic, it's come up obviously a few times today, and we've already commented on the need to consider having another briefing specifically dedicated to long COVID. We've had a couple of questions, probably for you specifically, Dr. Bakshi, around what the process, like taking a patient through that sort of long COVID recovery process. I realize it would be different for every individual, but just from your clinical experience, what that journey has, on a mean level, sort of looked like for humans.
Sure. I would need 7 hours to talk about this because I'm very passionate. But really briefly, I would say that identifying first of all that it is long COVID is really important. I think for the patient, for even the family of the patient. We don't talk often about the caregivers of patients who are living with long COVID, but oftentimes, at this point, I think myself and a lot of the folks that are really immersed in the long COVID world, we kind of identify what the patterns of symptoms are, and you either fall into like very severe fatigue, severe autonomic dysfunction, which can cause syncope, which is passing out, or palpitations, chest pain, whole host of other symptoms. And the first step always for myself and really any physician involved is to identify what are the treatable things, what are the things that we can provide symptom management for. But I think one of the most important things that we are recognizing in the long COVID world is actually the importance of rehabilitation and finding the right providers that really help with pacing, learning how to manage life, what it looks like right now. And on average, I would say most patients with long COVID around the 2-year mark start to identify that they might be feeling a little bit better in some of their domains. I'm not at the point where I can say people just magically cure themselves from long COVID or long COVID goes away. I do think it's a chronic illness that unfortunately many folks are suffering with. But I think the strategy is that over time, we start to learn with what are the triggers, what are things that make things worse, and how do we help you still have a quality of life.
And further into that, and then once we're done with this question and anybody has any other comments, I will invite any of the media that are in the room to ask some questions as well. So if you are a media currently in our little room at the moment, please turn on your camera. You'll be backstage. No one can see you yet, but that way I will know to pop you up on screen to ask said question. But on that topic, what types of cognitive difficulties are being investigated through testing in folks with long COVID, as well as what types of interventions have you been trying with folks?
So currently there is no standardized cognitive test for long COVID. So a lot of the testing that we use for patients with ADHD, with cognitive impairment, we're trying to extrapolate that for long COVID. There are a variety of different tests that a really great occupational therapist can do. A lot of the occupational therapists that I refer to in Edmonton are folks that are familiar with traumatic brain injury, with concussions, things that involve challenges with memory, recall, comprehension, focus. Those are kind of the biggest domains that we see in long COVID patients. Word finding difficulties. I always kind of say, well, you know what you know what you want to say, but the actual process and the ability to say it and do it is very challenging. And then there's also fatigue. So cognitive fatigue is a bit different than memory and recall. Cognitive fatigue is the processing speed. So you're just physically drained, and so your brain is just a part of your body and also quite drained. In terms of therapies, it's a very individual based, and I think that it's really important to understand what the individual patient is in front of you. I am utilizing a number of therapies for autonomic dysfunction, such as heart rate reducing medications, if that's the issue, things to help increase the blood pressure. And I'm also utilizing low-dose naltrexone, which is a medication that can help with chronic fatigue. But I think it's still really important that every one of my patients is still case by case, and I don't have a one-size-fits-all.
Before I invite Julie from CBC into the conversation to ask any questions that she may have, Dr. Vipond, Dr. Gasparovich, do you have anything that you would like to share on where our conversation has led us today?
I have a quick comment, and I think it's for a lot of. I just want to emphasize why I really care about this. I mean, people dying and going to the hospital is horrible, and I feel for every one of them. But based on what Dr. Gasparovich has said about the risk of long-term illness from every infection, and what Dr. Bakshi has said about what that impact has on people's lives, I think we really need to start thinking about where we're going as a society. If we're going to be allowing people to get infected once a year or once every 2 years, my 15-year-old is going to have 7 to 15 infections over the next 15 years of her life. And we have no idea what that is going to mean for her as a person. Right now, just today I saw a report about air traffic controllers being in high demand because there's a staffing crisis. We of course know about the healthcare staffing crisis. There's an education staffing crisis. I was on the BC Ferries last week. There's a BC Ferries crew crisis. It's not all burnout. Like, not all these people are burning out at the same time. There's something else going on here, and I'm concerned that an element of this is people no longer being able to work because they no longer have the cognitive or physical ability to do so. And we haven't thought out as a society what this will mean for us if we continue on the path, which is basically, it's 2019, do what you want. There's no need to behave any differently than you were in the pre-pandemic era. It's a bit of magical thinking and a lot of magical thinking, and I don't think we have thought it through. I'd love to hear Dr. Gasparovich's thoughts on and Dr. Bakshi's thoughts on that.
Yeah, I think I can echo everything what Dr. Vipond said. Like, I agree 100% with that. And then so basically, what is really worrisome that we will have more people that need help and need care, and less people who can provide this care, whether it's mothers, grandmothers, people from the society that are doctors. So it's really, really not a good trajectory. And at the same time, SARS-2 is simple. Like, it's not unbeatable virus. Like, we can. So, for example, like, positive things about it, easy things about it. It could be much worse. It could be like, it could have some kind, like, a bacteria that have spores and you cannot eliminate them. They stay in the room forever, right? Or you have to have super duper disinfectant to kill them. Like, after 2 days, COVID dies out in the environment. Also, only small percentage of people, when infected, can be infectious forever, right? Vast majority of people is infectious only during, 10 days, 14 days. So it's not like HIV used to be. So that's also a positive thing in it. And we know how it transmits. It transmits through the air, and we know how to clean the air. And we know we have super great respirators designed in Canada that we can, like, prevent sharing contaminated air with others. So, like, probably in several weeks we could stop it if we would use everything. And we have vaccines. That if you would vaccinate, like, there are studies showing that, like, models showing that if we would vaccinate everybody like 3 times a year, but like as many people as possible, also we could drive transmission down. So that's, we have all the tools.
Thank you all so very much for your thoughts and comments today. I'm going to invite Julie from CBC on to ask a question. Julie, if you would like to have your camera off, just turn on your sound and I will pop you into the conversation. That way you don't need to be broadcast to everyone at home, but I will throw things over to Julie now. Oh, Julie, we can't hear you. You're not muted though. Julie, we still can't hear you. I saw your fancy little headset on. So I know we should be able to.
AV. Always AV.
Yes. Well, and I know Julie is with us because Julie's turned on and off her camera as I have been speaking with her. Okay, Julie, I'm going to pull you back out for a second. That way we can try again. Okay. Julie, I'm going to pop you back in now and let's see what happens. Hello, Julie.
Does she want to type her question out and maybe
In the private chat? Yeah,
Mhm.
Julie, you could type it out in the private chat if you want, which you will see on your left-hand side. And I'll pull you back out again. One second, everyone.
Just while we're doing this, I can fill in some air. And just to say that, you know, when it comes to deaths versus disability, if you're ever have the misfortune of having a medical legal case, you'll always be found for more costs if it's disability rather than deaths. Even though I think intuitively you always think, well, it's worse to die, but you have to take care of disabled people for the rest of their life. And so, in a lot of ways, we, you know, to have this percentage of the population that's getting disabled with every wave kind of speaks to the impact it will have on society.
As much as we're getting ready to wrap up, I completely relate to those thoughts, Dr. Vipond. My primary practice is within the disabled arts community, and I am a human who identifies as disabled, both neurodivergent and living with a chronic illness of my spine, which also adds the physical disability. But it's, I love me. I love my life. I love who I am. All of those things have really, really shaped me. It makes me very, very sad to watch some humans consciously choose and or governments and policymakers consciously avoid sharing the full picture to keep people safe, knowing that so much ongoing long-term suffering is going to occur. And yeah, it is interesting to see, not interesting, it's terrifying to see what that is going to look like over the next 10, 15, 20 years as these things continue to affect us all. I'm going to ask Julie's question, and I am also going to bring in our fourth panelist, even though we are about to say goodbye, because they have joined us and I am excited and they would like to share 30 seconds of their lived experience with all of this. Please welcome Pop Alberta's Dr. David Keegan to the conversation. Hello, Dr. Keegan.
Hello, it's so great to see you, Michelle, and everybody again. So I'm a family doc. I'm caring for lots of patients with long COVID, people in their 40s with some cognitive dysfunction. Happily, one of them resolved spontaneously after about 6 months. 2 other of these patients, not yet. We're working on very customized treatments. But what Michelle just said is correct, is that there's been a framing of COVID as being only the acute COVID or the immediate infection being important. And actually what we're realizing, no, it's all the long COVID. It's the 40% increased risk with each infection, increased risk for heart attack, stroke, and so on. And so to Julie's question, it's what are we hoping to happen is
I hadn't shared Julie's question yet, David.
Sorry,
you're so ahead of the game. David's way ahead of the game. I'll get everybody up to speed on Julie's question here, and then I'll throw it back over to you to answer first, and then we'll have everybody else join in. Julie from CBC was asking if we could talk about the importance of why doing this briefing now and what impact we hope to have, as well as the follow-up to that is addressing COVID fatigue that came with all of the urgency originally and that sort of ongoing lack of ability to maintain or desire or all of that jazz. David, Dr. Keegan, please continue. I'm so excited to see you. Thank you.
So the issue, Julie, is that unfortunately, we've had leaders in positions in politics and public health who cast COVID as being something that would disappear once vaccinated, best summer ever, all of those things. And those have been disastrous because of not only the people who have died from acute COVID, but the many more people who have become disabled or acquired or experienced new complex other disease, whether it's immune dysfunction caused directly by COVID, ongoing COVID symptoms, what people often call long COVID, or the fact that COVID as a virus directly triggers a whole bunch of other conditions, type 2 diabetes, heart attack, stroke, blood clots. I'm somebody who's had blood clots myself, and that's like a life-threatening condition, and I'm lucky that mine were caught before that, before like I died. And so that's what we're worried about. And COVID fatigue is real. You're absolutely right. People are tired, but they're partly tired because there's been messages minimizing the contagiousness of COVID as an airborne disease, and minimizing and denying or not even bothering to talk about the ongoing disability. But what it really comes down to is COVID doesn't care. So if asbestos didn't care that people might have had asbestos fatigue, but we didn't give up. People are still doing asbestos remediation now. Why? Because it's a deadly, dangerous condition. So we don't have asbestos fatigue. We don't have diabetes fatigue. We don't have, broken hip fatigue. But for some reason, partly because of these atrocious signals that have been sent out by leaders that have minimized and guessed wrongly that this next variant will be benign, that actually, the public has become fatigued because they're hearing different signals. The problem is COVID is still disabling people. And we need to recognize that COVID is airborne, and the best way to prevent COVID, long COVID, is to properly prevent the transmission of COVID itself. I'll let my colleagues here add further. Thanks.
I can go next. Great to see you too, David. I think the importance of these briefings is partially education, right? I think when we first started these briefings years ago, it was to fill the gap that we weren't getting from public health, from the government. And I think, to be honest with you, as David rightly mentioned, I think when I'm talking kind of Alberta in general, or even the world, politicized something that is actually not political. It's an illness. It became very hard to kind of figure out what the noise was and what's real. And I think, as he rightly commented on, we don't think of diabetes as political. We don't think of cancer as political. We don't think of hips and knees and back pain as political, or even mental health as political. And really, COVID should be no other. When I talk about COVID and when I talk about my long COVID practice, I have no agenda except that the patient in front of me needs some help. Kind of going back to something that Dr. Vipon had mentioned about, we don't truly know the impact. There was a study done in the U.S. that showed that there was between 2020 and 2022 was $200 million economic impact of patients with long COVID or disability from COVID that would make them unable to work. And I'm sure that number is quite a bit higher at this point. I can tell you that the number of patients in my practice with long COVID who aren't working is above 50%. And these are from all various professions. This is not just healthcare. This is from every profession. And until we can get policy change around recognition of long COVID as a disability or COVID-related injury or illness, things that you may have gotten because of immune system dysfunction, until we can get those things addressed and understood by government and policymakers, we have to keep talking about it. We have to keep getting it out into media. It's things like my patients not getting their CPAP machine covered or their medications covered because it doesn't have to do with COVID because we can't prove it yet, when all of these things may have started after they got COVID. So, we have to keep talking about, we need to provide that education. And I think this forum allows us to do it in a non-political way, which is really important.
I'll go, and then Goja can wrap us up. I think I just want to emphasize one word that Dr. Bakshi said. It's policy. We live in a society where we've decided to be in a collective, to work to help each other, and that society has done very well for us. I mean, look at what we've created. It's amazing. And one of the things that helps us to make better society is better policy. So what are some of those policies that we could envision happening. We, at least I guess I should speak for myself. I don't think we need to go back ever to 2020, lockdowns, not seeing your loved ones. We actually know so much more about this because we know that it's airborne. We can put in pretty simple measures to mitigate transmission. That means, at the minimum, I would say, improving school ventilation, improving school filtration, putting in thresholds for times where masking would be deemed essential. And I sound like a broken record, but maybe we should never get rid of masks within hospital spaces until the COVID issue is dealt with, because it seems to be a nidus both for infecting susceptible patients, but also to get things back in the community. So if we really focus on those shared indoor spaces like schools, like hospitals, and other shared indoor spaces, we can make we can make a better space, so that we can do the things that we love to do with the people that we love without endangering them. So I hand it over to Dr. Goja.
So yeah, we've learned so much during the last 4 years. Okay, I learned a lot. I learned about aerosol transmission, what it means, and yeah. So we have all these tools, and we could basically, like, if we are a good society, we can use all our knowledge and be visionary and do with air what we did with water and with sanitation in the early 20th century, and sort of go back to 2018, but better. Like, we could have much less all the viruses and bacteria and pollens and such things that transmit via air, and basically get rid of post-viral infection, post-viral complications, like we did with cholera and other pathogens. But now that we can do it with pathogens that are in the air.
Thank you all so much for your time today, and thank you everybody at home who joined us and from the media. As always, an hour is never enough for any of these conversations, and thank you all for bearing with us for the 12 minutes over the hour that we have gone. I've been steadily watching the number of active viewers increase, and it has been very heartening for all of us. We will be back for 2 more pop-ups, at least that we have planned at the moment. One next Wednesday at 4 p.m. on family healthcare, and another one TBA on the current state of the ever-growing potential privatization, we'll say for now, the date of which is TBA. So please follow us either on X, formerly Twitter, or set those YouTube notifications to let you know. I did notice a few comments off the top of folks saying this was a notification I wasn't expecting to receive on my YouTube. And so thank you for still having your notifications set to let you know that we were popping up today. So I suppose, as always, stay safe, Alberta. We do know what to do. We do know how to help each other and how to keep those we love and those we don't know we love yet safe. Until next time, thank you so very much from all of us at POP Alberta for joining us.